Well, hello, everybody, and welcome to another Pilates Hour. Today, I am super privileged to have a dear friend of mine for decades now. I won't tell how many decades, but Bob Turner with me, physical therapist, licensed acupuncturist, and oriental medicine practice. Bob, it's good to have you on a webinar.
Thanks for inviting me today.
You know, I always think it's funny because I don't know, most of the world knows that you're married to the infamous Kim Gibilisco. And I know Kim's listening in, so I just wanted to make sure I do a shout out to your partner in life and your partner in practice, and just a beautiful educator for us in Polestar, and has trained a lot of our educators and a lot of our graduates in the Northeast and all around the world. So great to have you today. We picked the topic, and I know that it's one that's dear to your heart. I know it's one that you and Kim have worked on emphatically, that you have education courses and workshops already up. And Bob and I go back. Our first host site in New York years ago was Bob's physical therapy practice in New York. And even before that, Bob and I had worked together in the Performing Arts Special Interest Group and in IADMS and the dance medicine world, going back into the early 90s. And so we've gone and come a long way, baby, I guess they say, for that cigarette commercial that I'm not promoting. But it's good to have you, Bob. And I think that we're in for a good surprise today talking about it. I often think that, you know, like Kim, I also have had a lot of hip injuries and pathology and arthroscopic surgeries, and we've shared those woes together. And you really have an incredible handle on the hip, and particularly hip impingement and shallow hip, and all kinds of things that go along with the labrum. So I'm really excited about having you on today. And I know we're going to have lots of questions, so I figure we should just jump right in and maybe tell a little bit about your interest in the hip and, where that's come from, besides treating me and Kim.
Absolutely. Working in dance medicine for so many years, there's a handful of injuries that are really common for dancers. Hip issues, foot and ankle issues, and spine are really probably the top three of anything. And of course, you have your knees, your necks, your T-spine stuff. But, going back in time and, early in my career treating professional dancers, hip pain was such a common complaint. And, we didn't have the imaging, we didn't have the surgical techniques, we didn't really have anything. We were flying by the seat of our pants, and it was, the hip feels like this, the other hip feels like this. So I need to try to get both of these hips to function in the same way. And that was not always easy to figure out. It was fraught with a lot of pitfalls. And, what I'm looking forward to today is just sharing some of those insights, and also to, bring our communities together, bringing physical therapy and Pilates together. Because one of the things that Kim and I have really figured out over the years is that the combination of the two is so much more powerful than any one individually.
Yeah.
And it's really important to know when you can rely on the other and when you should rely on the other, understanding the scope of your own practice and when you need to reach out if something doesn't seem to be really going the way you think it should.
Bringing that up, I think back of just how blind we were to internal derangements in the hip. I mean, it either was, you had necrosis of the hip or you needed a hip replacement, but nobody talked about labral tears really, and nobody talked about impingement. We had psoas tendonitis and those kind of things that we all dealt with. But I remember the first time, and this was probably in the late 90s, I had finally a pretty severe injury to the labrum, and I met Dr. Mark Philippon. He was down in Florida, and he was one of the first surgeons of a group of maybe 10 or so in the country that were, really developing the tools to be able to create the space to go in and do arthroscopic procedure of the hip. But before that, the first 10 years of my practice, I literally don't. I mean, I think I was the first one that I knew in my practice that had a labral tear diagnosed and treated with arthroscopic surgery with Mark Philippon. I don't even think he had finished his residency yet at that time. So that was sort of how fresh it was. And I think when people realize, like we talk about all the time now, and it's often overdiagnosed. Oh, you got a labral tear. All dancers have labral tears. You probably got a medial anterior labral tear. It's like, but we just didn't know that kind of stuff. We didn't have the ability to find out. So
That's
just
right.
reiterating that.
Yeah. And, one of the things that, dancers would always ask me to do is to pull their hip, to pop their hip. And, and then it would feel better. You'd get a big old crack. I mean, when I think about what I used to do and what I know now, I never do those things anymore. I used to put people on a figure 4 and just whack that knee down there and pop that hip or traction it and pull it out and turn it in and out. And, like really.
Traction was my favorite.
What's that?
Traction was my favorite treatment. Like if I just get somebody just to do a long axle traction on it, and I'd get that clunk, and it's like, and I knew that I probably, Philippon said that I had a bucket handle tear, and that's probably what was going on. And later on, when in 1999, I think is when I tore the bucket handle tear, and that's when I had to have surgery. But it was like, up until then, it was just like, hey, can you pull my leg and give me some traction, and I'd get some relief. And now thinking about it, it's just like what you would expect with a knee or something with a meniscus that we just, I didn't. I don't know if others didn't, but we just didn't make that correlation that you could even do that with a hip.
Yeah, agreed. I don't think anybody really did. And it used to be that it would take in the early days of diagnosing these issues, it would take about 26 months to get to an accurate diagnosis. You would go through x-rays. Oh, do you have arthritis in the hip? Are there bone spurs? Then it was, do you have an inguinal hernia, a sportsman's hernia? Do you have a cyst? Is it just a snapping psoas? We would go through all of these things, and it wasn't until Philippon was studying with Reinhold Gans in Switzerland, and they were really the pioneers of this, of these surgeries and of the imaging. And, as we've gotten more clear imaging, I think that has really helped inform our practices, and it's helped inform surgical interventions. And, I think what's important to note, and as you had mentioned, labral tears now in the hip are sort of like almost a dime a dozen these days, but not all of them are surgical.
Correct.
And that's really one of the takeaways that I wanted to talk about today, is that you really need to go through a movement sequence. You need to facilitate qualitative movements and improve proprioception and correct movement dysfunctions before you even think about going into the surgical OR. And the use of intra-articular injections and oral anti-inflammatories and things like that are all really helpful. And you may find in working with a Pilates instructor that really understands the hip, that a lot of these things, just like we've learned with the knee, not all meniscal tears in the knee are surgical, not all labral tears in a hip are surgical. You really want to go through this arc of care first. And surgery is sort of the last option that you have, because anytime you invade a joint, it is never the same. It's not a pristine joint anymore. You've invaded it. They have done a lot of research and found that if there's some arthritis in the hip, once you scope it, sometimes it perpetuates an arthritic flare. And then you're ultimately worse off than you were if you just managed it conservatively. So I think that's a point that I would really like to make to all of our viewers today, is really do due diligence with movement reeducation before just sending someone to the surgeon. Now, that said, understanding what's going on internally to that hip is important. So I do think imaging is super helpful, so that we all understand, what are we working with here?
Yeah.
Because
there is such a difference, like a cam lesion or something that's bony versus, a basic meniscal tear or disruption. Just teaching really good exercises can often prevent it from getting worse, and certainly better than surgery. And then, those that I've seen with cam lesions have just forced their way through it without thinking about it, and have just done, an enormous amount of damage to the capsule and to the labrum as well, and the bony structure. So
absolutely. Since we're talking about that, Brent, do you mind if I just jump right into, I have a couple of videos that I wanted to share.
No, take it up there.
Give people a visual image of what we're talking about here. So the labrum is this blue structure around the hip here. And its function is to stabilize the femur in the socket by making the acetabulum a little bit deeper. So you can think of it sort of like that thick rubber ring on your toilet plunger. You got this thick piece on the edge that helps to create the seal for when you're using the plunger. And then that helps to increase the congruency of the joint. And it also creates that suction seal, just like your plunger on the toilet. You need a little suction to move the clog. And that's really, that suction is what the labrum does. It kind of hugs around the head of the femur here. And then, of course, this has all the joint capsule removed, so you can't see that, and you can't see a lot of the other musculoskeletal anatomy. But I think just to understand what this looks like and what the function of the labrum really is.
Such a great image. Even seeing where the tear is too, and realizing that.
Yeah, exactly. And so, we were talking about a cam lesion. So I have this animation here, and you can see this bump in the femoral neck here is the cam lesion. And when you flex through the hip, that comes up and crashes up into the labrum and then up into the acetabulum. And then you start to get this irritation to the labrum, and you start to get irritation to the bone. Okay, and so that shows us that with repetitive hip flexion, when you have this bony block here, that's not, you can't push through that. All you do when you push through it is you aggravate the tissues even more, and then you have something that gets red and swollen, and then the cartilage can displace off the inside roof of the acetabulum.
Bob, on that video clip there, sort of showing that, flexion, external rotation movement of the femur, and thinking of so many dancers and movers, soccer players in particular, that suffer from cam lesion because they, sort of ignore those early signs, like they keep bashing into the cam lesion.
Yeah. That's right. And then, they think, oh, it's my psoas, because, the psoas is coming right down across the front of the hip here. And so that in the early days, that's often what we treated. You'd go in and release the psoas, you would traction the hip, you'd manipulate the hip, you'd release the adductors, probably the deep rotators in the back side, all to try to help restore normal movement.
Yeah.
So that's what a cam lesion looks like. This next image that I want to share shows you what a pincer lesion is. So same idea. Okay, we're going to watch this animation go through. Now here, we do not have a cam lesion. You don't see a big bump on the femoral neck here. It still has that nice curved shape to it. However, if you forcefully flex the hip beyond its anatomical limits, you will still impact the labrum and the acetabulum. So that repetitive blunting or trauma to those tissues can create an overhang of bone right down here. And that's what they are calling the pincer lesion. Now, most of the time, you have a combination of the two. You have a cam lesion as well as a pincer lesion, because when that cam keeps bumping up into...
While you're doing that, there's just a appropriate question coming from Sarah Edwards in England, and she says, is the cam lesion something that develops over time, and is there something that triggers it? So sort of keeping that in mind as we talk about the cam and the pincer.
I saw that, and that's why I was bringing this image back. The cam lesion is not something that develops over time. They believe that it is possible from when we're an infant and the hips start to model, the hips are often, kind of pointing way out to the sides, and then they swing in as we mature. But as the epiphyses heal and harden, they think that maybe the epiphysis that's right here might have been slipped a little bit. And then that creates that extra bump in the bone. And then once you have that, the only way to get rid of that is a surgical excision. Now, I do want to credit Brian Kelly at HSS. He's the one that put these graphics together, and he's allowed me to use them in our talks. And I find them very helpful for giving you a really good idea of what's happening inside the hip.
Yeah.
Okay, and we talked about this briefly earlier, but just, a few things to keep in mind as we're working with patients with hip pathologies. Oftentimes you have these labral tears, cam impingements, pincer lesions in the younger population. And then as we age, that continued irritation to the bone is what's going to cause some bone spurring or osteophytes. The cartilage, as you saw in those images, starts to peel back or just get destroyed. And then that will progress into arthritis. And then ultimately you're looking into a hip replacement as you age. So the ideal here is to try to tackle these issues early and prevent, or at least slow down, the progression of osteoarthritis in the hips and then the need for hip replacements. But often, like I said, patients were frequently misdiagnosed for years with psoas tendonitis, sportsman's hernias, a whole host of other things, back pain. Is it the back that's referring to the hip? And then what's interesting is the presentation is really different in women than in men. Women, because they have so much more mobility in their hips than the average male, they're going to get to those end ranges more than we may, because we're going to have a lot of soft tissue tightness and muscle bulk getting in the way. Women tend to be more flexible within the pelvis and in the hips, really to accommodate birthing and making room in the birth canal.
A quick question on that. One is also, I want to make sure we hit like dysplasia or shallow acetabulum as far as a risk factor for some of these as well. So I know that, we do see a little more, obviously, dysplasia in the women pelvis than the male pelvis, but yes, they both can have that.
Sure. And so, with hip dysplasia, or you could have, so hip dysplasia means there's not enough coverage of the socket over the femur. So we could be undercovered. So the socket is shallow and the head of the femur sort of hits right at that point where the labrum and the edge of the acetabulum are, and that's going to wear that out. You could also, there's an opposite issue, which is what's called a profundus hip. So that means that the hip is very deep in the socket. The socket really overcovers the femoral head. And then when you raise your leg, you might bump into that. Now, these are two opposite ends of the spectrum, but you could have, in Kim's case in particular, which, we always made this, I've learned a ton working with Kim with her hips, because one of the things that made her extremely beautiful as a dancer was her flexibility. She could do a 190 split. Like she could go well over 180. But she has a profundus hip. She also, though, has a hypermobility syndrome. So she has Ehlers-Danlos, and that makes her so flexible that she has gone up and bashed into the edge of her labrum multiple times in her career. And early on in us learning about the imaging and the issues with the labrum, the initial surgical procedures were just like in the meniscus. Oh, let's go in and trim it out, take it out. The problem with that is you would lose that suction seal. So now you have this micro instability of the hip, And then the soft tissues around the hip have to work triple time, quadruple time to try to stabilize that little micro instability.
Mm-hmm.
So then you start getting a lot of issues with muscle tightness, spasms, guarding, pain. And so you can have an intra-articular issue that causes a lot of extra-articular problems. Now, as Pilates instructors and physical therapists, we can really address that extra articular stuff. But when it comes to internal derangements, we're pretty limited on what we can do with that. And we have to really rely on what we are able to change, which is someone's movement strategy. And once you do that, that can really help. The treatments for surgery, the surgical procedures vary by clinic, by hospital, by location, by surgeon. So it's just important to know locally who you're working with. What types of procedures are they doing?
And going back in the day too of the early arthroscopic procedures, I mean, there were, again, they were discovering everything, just like what the knee arthroscopy went through in the 70s and 80s. That happened in the late 90s to 2010. They were still doing things like thermal shrinkage or microfracture on the head of the femur, and the thermal shrinkage on the capsule. Those of us that went through that procedure, by the time we got to a total hip replacement, they were like, your capsule was destroyed with the thermal shrinkage. They don't do it anymore because now they know. But it was like you're right that it's not one shoe fits all. And I think that, if you look hard enough to find somebody that will do arthroscopic surgery on your hip, you will find that person. And I think that's really why we want to educate people today. Like, what are some ways that they can really be aware and savvy as to things to look for? What are some other pathways that they can take before they get to the surgeon, and how they find a good surgeon, kind of thing, are all really important questions, I think, out there for the general public at large.
Yeah, and I just to kind of tandem off of that, you don't need to start with a surgeon. Start with a good physiatrist or a sports medicine doctor, a good orthopedic. They don't have to be a surgical orthopod. They could be a non-surgical. Get your imaging, understand what's going on with the imaging and the symptoms, and trying some of the conservative measures prior to going into the surgeon, because they're going to say, what have you tried so far? And it's no mystery. Surgeons make money on surgery. They don't make money on office visits. So they want to hit a home run. If somebody comes into their clinic, they want them to be surgical, because that's something that they can fix. These non-surgical things that we all manage are not things that they can really take care of. And so they're going to give them the boot and send them to us anyway. So I think going through, solid differentials and movement assessments and strategies is really the key to success with these things. Common problems or things that we see with people that have these internal derangements, we could have pelvic floor dysfunctions, we can have referred pain. It's important to figure out, is it coming from the back? Is it from the hip? Is it radiating down from someplace else? Is there weakness that's a pain inhibition response? Because, if something hurts, our bodies are smarter than we are. Your body is going to say, don't do that, it hurts. But we tend to be stubborn and want to push through it. And that's ultimately when we create a lot more trauma than just kind of getting some information ahead of time. It's important, as you're looking at hips, to look also, you have to start from the bottom. You have to look at the foot and ankle and the mechanics of the foot and ankle, because in the kinetic chain, if we have an issue downstairs, I often liken it to construction of a high-rise building or a construction of a home. They always dig a hole and set the foundation before they build the house. And the foot and ankle is that structure. That's the foundation. So if there's an issue with the foundation, like the Leaning Tower of Pisa, that's a structural issue from down below that caused the building to tip. So that's kind of the idea that we're thinking about here, that you have to really assess that.
And that's such a, we've talked a lot about the idea of, things like, for example, loss of ankle dorsiflexion, and as that would pertain to knee pathology or hip pathology and back pathology. And we so often aren't looking at the ankle dorsiflexion or aren't looking at the thoracic mobility. We're just looking at the symptoms that come from the lack of mobility or lack of strength and coordination or awareness of those joints. So I appreciate you bringing that up.
Absolutely. Now, I do see a couple of questions that I just wanted to tag on here real quick. And I'm going to start from what I can. The last question, can I dive a little bit further into pelvic floor dysfunction? I'm not going to do that here. That's a much broader topic than we have time to go into today.
Well, I'll bring on some pelvic floor. We have some great ones in the past, and we can do that on another time. So it's a great topic, and I love talking about it.
Yeah, but I can say with certainty that a lot of people with hip pathology also have pelvic floor dysfunction. Yeah. How do we determine the course of action with no imaging and dealing with an adductor, hip flexor pain, and limited range of motion? It's a movement re-education process. Do no harm. I think that's number one. If you're finding a provocative movement, you really want to try to modify that movement. Reorder your movement to see if you can do something that then allows whatever is problematic to become less problematic. It also may be that you have to leave it alone for a little while. Sometimes you have to throw a wet blanket on a fire to put it out. And when a hip is really inflamed, first, you might need to shut down the show for a little while and then start with re-education. And thoughts on cortisone injections. Cortisone injections are often used as a diagnostic process when someone goes in to see either the physiatrist or the pain management sports med doctor. And that's really how we will determine if an issue is intra versus extra articular. Yeah. So intra articular means the issue is inside the joint. And so they can squirt some cortisone in there with some
Marcaine or something,
or Novocaine or lidocaine or something to numb the pain, and then put someone through the offending movement to see if it helped. And often what you find, if you had complete resolution of all of your symptoms with that, then typically you're a strong surgical candidate, because that tells us that the issue does live inside the hip. Mm-hmm. If your hip pain goes down, say 50% or 25% or something like that, that tells us that there is a component that's intra-articular, but there's also a component that's extra-articular that they did not hit with the injection. So those are the parts that we as healthcare professionals and Pilates professionals can manage and deal with and get that part to go.
Yeah, and I always try to remind people too, like a lot of people are scared to death of a cortisone shot. Like we've heard all the nightmares of a cortisone shot, but for that to happen, you'd have to have repetitive ones and often close in time frame. So yes. Typically having it tested out and having that injection to rule out the intra versus extra articular problem is very normal. It's not a problem. I tell people where we get scared sometimes. We see somebody back in the 70s, they were injecting a lot of Achilles and patella tendons with cortisone before, a ballet performance, and or a basketball game, and they were blowing those tendons. Right. We certainly want to stay away from those days, but as far as a differential, it's a fantastic differentiator.
It's a great tool. It really is. And, I know a lot of people have apprehensions about putting medications like that into their bodies. You hear those horror stories, and true, but again, that is with that repetitive use of those medications. If you're having pain, so part of your differential for intra-articular hip pain and a labral tear specifically is if you flex the hip over 90 degrees, you internally rotate it, and you adduct it. You adduct it across towards the opposite shoulder. And if that's what we call a fader test, which just stands for flexion, adduction, internal rotation. That, and if you do it with a quick movement, and I don't recommend Pilates professionals do this, it's not within your scope of practice, but you're also, if you're a PT, you can do this. And that's really how we will run someone through a diagnostic in the absence of imaging. And I do see a question over here. I didn't read through it completely, but if there's bone spurs in the joint, what modifications might we do? You need to know what you're looking at. And I'll come back to that question again in a little bit, because there's a couple different layers to it. But the intra-articular injections with the cortisone can help that hip to feel better. And then we have to start re-educating that joint and that person. Really, it's not the joint, it's how they move. It's someone's movement strategy. So just to finish this slide off with common problems found, when you have pain in a hip and the psoas tendon is traveling across the front of the hip and lays, you have your psoas tendon, and then you have your joint capsule, and underneath that is where the labrum is. When the labrum is irritated, that can cause an inflammation and an irritation that pushes up into the joint capsule, and then now the psoas is running over a bit more of a bump than it ever had before. So it tends to get really irritated, and it can hypertrophy. And when it does, and it gets thicker, the muscle gets stronger, it gets thicker, that'll negatively impact the disassociation of the joint. It'll decrease the dissociation. It affects that rib to pelvis relationship because of the origin of the psoas coming from up around T12, and then passing down to L4. Its attachments are T12 to L4. So when the psoas gets really hypertrophied and tight and irritated, it's going to now reduce your spinal mobility. And that's part of what makes these things kind of complex to figure out. So going back to this question about someone who has bone spurs in the joint, modifications, I would really start by working in the spine and the core. Get the spine healthy, separate that out from the hip. Then you can add in hip movements that maybe were offending, but modifying the range and modifying the load. The beautiful thing about Pilates is, we have feedback from the springs that are really going to facilitate that proprioception and the qualitative movement. Unload the hip, re-educate it, and then progressively load it up into a weight-bearing position. And that's, I think that's part of the Polestar principles, right? Working through multiple orientations to gravity, and then finishing in an upright position.
And along those lines, Bob, too, I think it's, you hit it right on the nail right on the head. Is, if we are able to get mobility in other surrounding joints. Particularly this question that Annie has about, the bone spurs. You're not going to change necessarily the bone spur effect on the range of motion of the hip, but if the back was more mobile, if the ankle was more mobile, if the thoracic was more mobile, the likelihood of them being able to participate at a higher level than they would if they started having all of the restrictions. So we say distribution of movement equals distribution of force. We want to decrease the force around those bone spurs. So how do we do that? And we do it by modifying load. So right on the money.
And then thinking too about, again, going downtown to the foot and ankle. There's been a lot of research done on, say, the sound of a landing from a jump. This was a 1996 JOSPT research article.
Remember that.
If you cue somebody to land softly as opposed to landing with a thud, you reduce the ground reaction forces going up the chain. Because if you don't have good shock absorption through the foot, the hip is the next joint to take it, because they increase the forward trunk flexion through the pelvis and the hip. So the hip takes a big hit. Yes, the knee can take a hit too. It all depends on the activity that the person's doing. That's why we have to really analyze movement. That's why Pilates is a perfect environment for us to do that, because you can change the load, you can change the position, you can change all types of things.
We've been playing a lot with that too, and I think this is a perfect time for it. Of separating out what a Pilates teacher should be able to do versus what a physical therapist does. And, if we're looking at movement that corrects with things like cueing or changing the load, we're probably within our realm as a Pilates teacher. When we look at things and we realize, wow, they don't have any dorsiflexion, or they are having this, loss of range of motion in their hip, and we can't cue it away, we can't unload it away, that's probably telling you that that's when you refer out.
Right.
And vice versa. The physical therapist is really sensitive to this, knows that anytime we are manipulating joints or working with tissues, and that they need to have the reeducation, which is where that nice synergy between the Pilates teacher and the physical therapist is, that they always need strategy, which is the Pilates teacher's strength. They don't always need to have structural intervention that like Bob and I would do. So, I think that that's a nice way of differentiating, that if you can cue it, if you can modify it with load, and you're successful with it, then you're in the right place. If you find that you have to do something with force, or something that is dealing with mobility or hypermobility, that needs to be referred out.
Yeah, absolutely. And I think along with the movement reeducation component is, when you have pain, you change how you breathe. And so working with the breath, working with, stress management, anxiety management that comes along with all of this. If you're having hip pain and then you start to get really agitated about it, it only gets worse because you're not breathing properly. So, really working on down regulating pain, especially if somebody doesn't want to take medication. We were talking about injections and oral anti-inflammatories or pain medications. Work on the breath, work on the pranayama, teach them to breathe, teach them relaxation exercises, give them some guided imagery to help down-regulate the pain cycle. The other thing that I think, especially for us, us older PTs, and I'm pointing to Brent and myself because we both did this and we both overdid this. You have to be careful of over-releasing a hip. When you have these pain syndromes and you have hypertonicity in the muscles, certainly you might want to do a little bit of release work to just down regulate that a little bit, but you don't want to over release what's holding them together. Particularly in the case of someone with an Ehlers-Danlos hypermobility syndrome. If you keep releasing them, you're taking away any sort of appropriate compensatory tightening that they have. So I think it's a huge mistake. And I've done this. I've done it with my hands. I've done it with acupuncture needles. I've released because people are like, oh, it hurts. But what you learn from that is if you're on the hamster wheel of pain, if I'm releasing you, you feel better temporarily. You come back to see me in a couple days or a week or whatever. You're like, yeah, it was good for a day. And then it came right back again. And boy, did it come back with a vengeance. It's because we over-released it and we did not give them the appropriate re-education. So again, I think it keeps coming back to movement re-education.
And your point the point you make, Bob, of the difference too of somebody that does deal with the hypermobility systemically, like Ehlers-Danlos, versus somebody who is, like if you have a sprinter that is, just genetically wound pretty tight, it's a very different experience. But they often don't typically have hip pain.
That's correct.
Yeah.
Yep.
It's those of us that were hypermobile that hip pain. And you said something that reminded me. I was about 10 years, maybe a little bit more after my first arthroscopic surgery, and I was in so much pain that particular time. And you came to Miami, and I had an out-of-body experience with deep needling of the iliacus, but it was like I had such an incredible release of just, I couldn't even find or identify, like I had a lot of myofascial release and it still wasn't getting to that point. But I do know what you mean of like, it's like I realized later of how much my neuromuscular system was trying to protect the integrity of the joint, which is why it was always so tight. Yeah, or
Yep.
felt so tight, I should say.
And I think there's an appropriate level of release that we can give someone to help with the pain control, so that then they can go through the movement re-education, the motor sequencing process more comfortably. It's the reason we do an injection into the hip. It's the reason we do oral NSAIDs, is to try to reduce the pain enough that you can do your exercises.
Yeah.
So when I'm thinking about surgery, you have this, everything is like a pyramid, right? And we have our movement, our day-to-day activities are sort of at the bottom of the pyramid. These are the things that we want to be able to do every day. Then we're into sporting activities, and we want to ramp up what we're doing. So that's a little bit higher. At that point, though, we might be starting to have some pain or some dysfunction. So we have to rely on some medications. The top of the pyramid is really the surgical piece. It's not for everybody. That's the smallest piece in the pyramid.
Yeah.
And ultimately, probably I would say 90 to 95% of people can have a significant reduction in their symptoms if they work on their movement re-education, if they work on their breathing, and work on just resequence the movement. This is just a few things. I think I've covered a lot of these things already. We need to be, when you have someone with hip pain and pathology, and this goes back to the person's question that said, how do you modify if you have bone spurs around a hip? You probably don't want to traction that hip. You're not going to scour it. So scouring is taking the thigh and moving the hip like full flexion and internal and external rotation. You need to be really careful of overstretching, over releasing the pelvic floor, over releasing those deep rotators. You have to shorten up those end ranges of motion to avoid the irritation. As things settle, you may be able to access that motion, but if you have a structural issue, structure determines function. If your structure is terrible and you're trying to functionally push through it, you're not going to help yourself at all.
And a good example, Bob, a good example of that is just, a dancer that is introverted that keeps forcing themselves to do turnout in ballet.
Yeah.
Is like their structure, they fight it their whole career. So you see things like, tibial and fibular torsions, and you see the horrible effects on their feet and on their back of them trying to, force their structure to act like, an aesthetic line that is inside their performance, right? And I think that's so important. A lot of time, and it's hard sometimes because people want to be a ballet dancer, or they want to be a long distance runner, but their structure is a major challenge for some of those movements. And we can coach them, but it's tough.
Absolutely. So being aware of what it is they want to get back to, and that's where we have precautions here, like impact sports, running, dance, tennis. You have to gradually return to previous levels and just be mindful of what it is that you're doing and what their goals as your client are. And just, when you have a labral pathology, repetitive hip flexion over 90 degrees is not really always tolerated well. So modifying that activity, if they can tolerate an elliptical on a lower incline, that might be better than an elliptical on a higher incline where we're going into that deeper hip flexion. Yeah. Same thing for like spin classes. In spin class, a lot of times, you're up and down in the saddle, you're leaning. I don't know all the names of the positions, but you're leaning forward on the handlebars, stomping on the pedals, and you're really going into some deep hip flexion. That's not always tolerated terribly well by someone with a hip issue.
Hey, Bob, we got a couple minutes left, and I was wondering if we could maybe spend a little bit of time talking about some of the exercises or movement that we can do as Pilates teachers with something like an impingement or a cam lesion, and things inside the Pilates. You certainly spend a lot of time doing this. What are some things that they could take home? You know, like one of the ones I love is just in a quadruped position with the knees wide, feet together, sort of, for me, like sort of getting the socket to the femur to drop back in the socket a little bit more, and gradually trying to come into a more parallel position, just sort of releasing some of the tension in the posterior capsule or the posterior muscles. But what are some of your go-to with people that are dealing with some, anterior impingement and labral problems? Is all pre-surgery, all trying to avoid that?
A couple of things. I think one is looking at like hip abductor strength. A lot of people notoriously have weak hip abductors. So when they go to stand on one leg, the pelvis drops. And that's creating an instability around the hip.
And that's Chris Powers' number one thing for knee pathology. So he always is talking about hip abductor and rotator strength is the weakness is the leading cause of knee injury. So
I completely agree. And I often think though, the knee is just stuck between the hip and the foot.
yeah,
So that's my approach.
I'm right there with you.
The foot, you have to look at the hip. The knee just it gets battered because of that. So one is, I think, hip abductor strengthening, ABAD. I like to put people up on the reformer, standing, a variety of positions, rotary discs, and really working on a lot of it. Or the core line is a nice place to do that. On the reformer, I think, working on circumferential conditioning, leg circles, modified depending on what they're feeling, to really get that rotational strength all the way around the hip socket. You don't want to focus on just the abductors and neglect the deep rotators or the glutes or the hip flexors or the adductors. You really have to work 360 around that entire hip, and you're balancing the strength, the flexibility, and the sequence of that movement. I think core control is key to all of this, because if we cannot control the core and the pelvis, the hip is sitting inside the pelvis, so we have to make sure that we account for that. And it's especially like deceleration control. We often focus on the propulsion phase, and then the deceleration phase is ultimately takes more strength, because we can lower more weight than we can actually pick up. So, you can jump down from a higher position than you can jump up to, because of just how the muscles function. So focusing on that all the way, and deceleration strength is through the foot and ankle, the knee, and the hip, and really paying attention to all of those pieces. So, we like to put people on the reformer on the jump board and look at the sequence of the movement, and then re-educate that movement there, and then tip them up into a more upright position to emphasize, an increased load.
That's such an interesting phenomena too, of listening to somebody jump on the reformer, on the jump board, and hearing the huge kibosh and watching the reformer slide 6 inches, and realizing that's the same strategy they have standing up. We just don't see the floor moving, but that ground force is coming up through those joints, and potentially long-term creating some havoc there. So it's a great tool to teach that sequencing.
I think too, when we're looking at exercises, just, I think, be mindful of dosing with anything that we're doing. Physical therapists are often criticized for not dosing properly, and I do think that is true. I think they tend to underdose people, underload them, and we ultimately need to load them more. But again, it has to be with good form, so working on the strategy and the sequencing first before load in any exercise. I think that's like a gold star day. You got to really focus on that aspect. And then you can start to increase the loads. And, when I see people with loaded weight vests jumping up and down on boxes at the gym, I get a little like, what are they doing? Because, they're going to come to see us sooner or later, or they're going to see the surgeon and they're not going to know why did it happen. And they're going to go right back to it again because they never really addressed the underlying issue. They think that the structural change, let's say from a surgical intervention, is the correction, but that's just a small piece of it.
Yeah. There was a small test that we do with people that want to run that haven't been running or deconditioned. And it literally is jumping off from like 6 inches or a foot high step on one foot and jumping down on one foot and seeing what their leg actually does. Does the knee buckle in? Do they have a medial rotation? Do they collapse in the arch of their foot? And, we also look at just jumping in place on a single leg at a fairly rapid rate for a minute to see if they fatigue. And if they can do those two things, then we know that their abductors and their rotators and the hip muscles are stable enough to be able to handle repetitive movement.
Yeah.
But take that to something like, soccer or basketball or dancing where you're pivoting and decelerating, accelerating. It's a multiple of forces that, far above what we would think of in walking or running because there's so many different directions. Yeah. And if we don't do specificity of training, like you're saying, right, then then they're not going to get the benefit of it. And that was, I know you remember those days where we would Cybex the heck out of people thinking that we were going to get that knee after an ACL reconstruction to get flexion extension strength, but it was so much more than that, right? It was the hip and the mobility in all planes and acceleration, deceleration, ankle. And that's the beauty of what we do. And I'm glad you bring that up because I think one of the things, a lot of times I just tell people, look, just do the Pilates, but do it from an internal feedback mechanism, like asking them what they're feeling as they're going through it. And you're probably going to make the right decision 8 out of 10 times if the client is involved in conveying what they're feeling. And then we have the tools to modify, to change the range of motion, to change the load, to change the orientation to gravity, to be able to create that positive movement experience. And I really appreciate that. You have an incredible example across the room from you right now. I was so impressed with her rehab, but I know there was an era of desperation and multiple procedures, and it didn't look like there was a lot of hope. And Kim has been so successful at working through both what you mentioned with the hypermobility as well as the surgeries and being able to still move at a very high level. I mean, she's not performing professionally anymore, but she's still such an incredible mover. I don't know if she wants to pop on real quick or something.
Yes, she is right here. I can tell you that, she is the hardest worker that I know.
Hi, Kim.
Hi, thank you for having me.
I just thought it'd be good to have you share a little bit with Bob's side of sort of, your journey on this because, you've had a number of these things that we've talked about today. And on top of that, the hypermobility and the dance career, and yet you've really overcome a lot of those, impairments. And I'm sure Bob's going to say how much hard work you do, much harder than I did, I think. But I would love to hear your story.
What I've learned is that it's a never-ending commitment. I am always working on my hip. My hip doesn't always hurt me, but I always have to give it care. And there are periods in my life where it's sort of like ebbs and flows. But when you have hip pathology, if you can accept that it's a lifelong journey of learning and evolution, I'm stronger today than I was 5 years ago, and I'm 51 years old. Usually after you turn like 48, 49 as a professional mover, your movement starts to go like this. You get a little weaker. I've been through menopause now. So, have all the issues, the hormonal issues aligned with, your muscle bulk and all the tissue issues that go along with menopause. I'm still stronger today than I was 7 years ago. Because
what are you doing, Kim, to keep that going? Like I think that's what I want the message to be. And it's such an important thing. It's like you don't just rehab it and it's done.
Right.
And Bob said that earlier as well. And just sort of like, what are things that you do on a regular basis to keep your hips strong, to keep your body strong?
Well, I move every day. I move with my clients on the mat every day. I still have a very healthy Zoom practice, which I love. I Zoom with people all over the world, at least twice a week, full time during the day. And then you've been to our house, Brent. I have a
Yep.
spin bike in my living room. And I use that spin bike very carefully because, as Bob said, you can get into hot water. What's good about the spin bike for my type of hip with Ehlers-Danlos is that I'm not thrashing into an elliptical pedal. I can sit when I need to rest, and I can go forward and I can go backward.
Yeah.
And the backward motion actually feels the best on my hips. So like I sign up for different online spin classes, but I do it at my own pace. I just use, the cues as a guide. So I'm doing the cardiovascular work. I'm doing the daily mat work, the apparatus work. My footwear is probably where I spend my most money and my most time. Is I have really specific footwear. When my Ehlers-Danlos is flared up, I'm wearing my ugly Dansko shoes, and I don't care. I just have to wear them. I wear compression garments. It's all about how I can get from point A to point B without feeling disabled. Because if I feel like a disabled person, the depression starts to set in.
Yeah, and I certainly can relate to that. Bob, you'll never guess what kind of shoes I bought.
Oh, did you get some Echoes?
I got some Echoes. I'm wearing them right now. I was over at Bob and Kim's house, and I go to the bathroom, I come out, and Bob's looking at my shoes like, these Danskos have had their day. They're done. You need a new pair of shoes. So they were going to escort me to get. I said, no, I'm independent. I'm going to get a pair of Echoes. I'm going to do it. So I'm wearing my Echoes. They feel good. Well, listen, we're out of time, and I want to thank you both so much for all you do in the community, in the field of Pilates and rehabilitation and dance medicine, and you're like family to me, and we love you guys and appreciate all that you do and your leadership. I do see one last question for me. If we were planning on doing the same thing with the shoulder joint and shoulder pathologies, and it's funny because I was thinking with Bob just having shoulder surgery, that it would be great for us to come back and do revisit another Pilates hour talking about shoulder. So we'll think about it. We'll see what we can put together. Anyway, thank you so much, Bob. Thank you, Kim, for sharing your story. I appreciate it. And just want to remind everybody, the notes in the show will have things that talk about Movement Collab, which is both Kim and Bob's company, an education company. They reside in New York. If you go to movecollab.com, you can see the classes that they teach and sign up for some Pilates classes with Kim. And above all things, just want everybody to remember to be kind out there. So we've got a crazy world out there, and if we can just stay focused on being kind, we can make the world a better place. Thank you again, and thank you everybody for attending. We'll look forward to seeing you in the near future.
Thank you, Brent.
Thank